Hello Health on LAE is presented by the Ochsner Health System, a nonprofit, academic, multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 7 hospitals and more than 35 health centers located throughout Southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health finance and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with LAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topic, living organ donations, and we have 2 guests tonight, Drs. Trevor Reichman and George Therapondos. Well, in the second half hour of our program, we're going to be taking your questions live by phone at 504-866-3200. That's 866-3200. We'll have it at the bottom of your screen. And by email, just email your questions to us at hhquestions@wlae.com. You can hold off on the phone calls for now, but send those email questions right away. Well, Dr. Reichman got his undergraduate degree from Bucknell University. He attended medical school in New Jersey at the UMDNJ New Jersey Medical School. He did his residency work in general surgery at the University of Chicago. After that, he continued his training in abdominal transplantation and hepatobiliary surgery at Toronto General Hospital and Children's Hospital with a focus in liver donor liver transplantation. He joined the Ochsner team in 2011. Dr. George Therapondos, to my immediate left, received his medical training in the United Kingdom at the University of Edinburgh and the Scottish Liver Transplant Unit. He spent time in Canada, in fact they both did, too, serving as an assistant professor and staff hepatologist at the multi-organ transplant program of the University Health Network in Toronto. He also served as the director of clinical trials there, and in 2011 he was elected as a fellow of the Royal College of Physicians of Edinburgh. Right now he's completing a master's in public health at Johns Hopkins University. He joined the Ochsner team in 2011. And it is our pleasure to welcome Drs. Therapondos and Reichman to Hello Health. Great to have you both with us on the program.
Thank you, Tom.
Thank you very much.
Thanks.
Dr. Reichman, good to have you.
Thank you.
Well, let's start by talking about what organs qualify as living organ donations, and let's start with you, Dr. Reichman.
So basically there's 5 livers or 5 organs that can be donated through living donation. The most common and widely accepted is kidney donation, and that's probably performed at most major transplant centers. Far behind that is liver donation or split liver transplantation, and then there's also some scattered reports of partial pancreatectomies, small bowel transplant, and also partial lung transplantation.
But by far, kidney donations.
By far, kidneys is the most widely accepted and most commonly used in the United States.
Very good. That gives us an overview. These next few questions will be for Dr. Therapondos. What is the function of the liver? Let's start with the liver first. Remind us. Take us back to biology class.
Well, the liver is the second largest organ in the body, if you include the skin. Mm-hmm. And it has a number of crucial functions without which we cannot function normally. So the liver produces bile. It works very well to metabolize nutrients and store nutrients in the liver. It also synthesizes a number of essential plasma proteins, such as clotting factors, and albumin that we all need for blood circulation.
If I remember correctly, in an earlier program, I was told this is one of the only organs that can regenerate. Is that the case?
Mm-hmm. That is correct. It can regenerate, and that's what gives us the opportunity to utilize the liver as a donor graft from a living person. Mm-hmm. The question I often get asked from my patients is, why does my liver not regenerate when I've got liver disease? And the issue is that the liver can regenerate in an abnormal way when you have an ongoing process.
That would make sense. Dr. Therapondos, how common is liver disease in general, and how about in Louisiana in particular?
Liver disease is becoming increasingly recognized as a common problem. It is particularly prevalent in other countries, and we know that approximately 1 in 12 people in the world have viral hepatitis, especially in Asia. And there are about 500 million people in the world living with viral hepatitis. In Louisiana, in the Gulf Coast, we have about 1 million people with liver disease in general.
Okay. What are the most common causes of liver disease?
It is a common misconception that liver disease is only caused by alcohol excess. It is true to say that alcohol excess does cause liver disease, and it is a fairly common cause of the problem. However, viral hepatitis, especially hepatitis C in the US, is one of the commonest causes. Hepatitis B is another cause, is another viral infection that can affect the liver. And we have a variety of other fairly rare inherited and metabolic diseases. The new kid on the block, so to speak, is what we define as non-alcohol related fatty liver disease, fatty liver, which affects probably 60% of the US population. I don't want to scare people, and I don't mean to say that 60% of the population have severe liver disease, but they probably have a mild form of fatty liver disease.
And this is due to mainly obesity and diet.
Exactly right. You know, we all recognize that there is an epidemic of obesity and poor diet and lack of exercise. And those factors are contributing to the rise of fatty liver disease.
Living in Louisiana doesn't help things. What are some of the signs and symptoms of someone with liver disease? And I know you brought along 2 images for us to look at as well.
Well, liver disease can present in a variety of ways. It can present very insidiously with very non-specific symptoms such as weight loss, generalized weakness, fatigue, excessive sleepiness sometimes. We often hear patients complaining about the onset or the beginnings of fluid retention. They have a swelling in their abdomen, for example, what we call ascites, and I have some pictures to show on that.
There it is.
That is the picture on the left. They all can also have edema of the legs, what we call leg edema. That is a symptom of salt and water abnormal processing because of the liver disease. One of the other symptoms is jaundice. People can have a yellow discoloration of their eyes and their skin. They can have a lot of itch and general lethargy. And the other serious problem with liver disease is that people can present with gastrointestinal hemorrhage. They can either start vomiting excessive amounts of blood or pass blood per rectum. And we had a picture on the right there that showed what we call esophageal varices, which are dilated veins in the lower part of the esophagus that can rupture and bleed, and that is a very dangerous complication from advanced liver problems.
Many people will have some sort of liver disease. Not everyone will need liver transplantation. Who will need a new liver?
Well, hopefully the minority of people with liver disease will need liver transplantation. In general, in children, the children that need liver transplantation are those with metabolic and inherited diseases. Each of those diseases is relatively rare. But of course, children also get adult diseases that don't usually present with alcohol problems, but they do get viral hepatitis, relatively uncommon in this country, but they can present with those things. In adults, we have 2 types of patients that need liver transplantation. Those that have liver failure when their liver is malfunctioning, and those that have primary liver cancer. Certain types of primary liver cancer that hasn't metastasized anywhere else outside the liver can fulfill criteria for receiving a liver transplant, which can be curative in this case.
Is liver disease something that tends to run in a family?
Sometimes it can. There are inherited diseases that can run in families. Most of the time they're not, though.
Okay. How many liver transplants are done in the U.S. each year?
There's a large number of liver transplants done in the U.S. each year. Last year, as you can see on the slide, the U.S. performed over 6,000 liver transplants. Unfortunately, 2,500 patients were unfortunate not to receive a transplant and died waiting on the various waiting lists throughout the country. That represents about 15 to 20%, depending on which state and which waiting list you're on. It is fair to say that a significant number of people that are placed on waiting lists never receive a transplant.
So the short answer to that is not enough of them when we ask how many received them. And we see how many people there were on the waiting list in 2011, almost 17,000 people on the waiting list. We turn our attention to Dr. Reichman now. We thank you for your patience. Sure. Let's talk about organs and how they are allocated in the United States. What's the system that is in place? Sure.
So currently in the United States, we utilize what's referred to as the MELD system or model for end-stage liver disease. And it's a system that was developed about a decade ago that basically is made up of 3 lab values that we can get from any patient who's listed for a transplant. That includes your creatinine, bilirubin, and INR. And those 3 values are plugged into a scoring system or to an equation that generates a score for you. And depending on how high that score is, you get ranked on a list. And organs are allocated based on where you fall on that list, with the object being basically to transplant the next available organ into the sickest patient as calculated by MELD, and also somewhat based on your blood type. The problem with the system is that the score doesn't always reflect somebody's disease severity. So in a lot of cases, we see patients who have low MELD scores but have a lot of the complications that George has mentioned previously, such as ascites. A lot of them are in and out of the hospital with infections and stuff. So those are the patients that unfortunately are very sick but have a low MELD score. And those are the patients that we lose every year on our waiting list to liver disease.
Is it like democracy? It's not a perfect system, but it's the best one we've got?
Exactly, yeah.
Has the system been tweaked, or is there talk of tweaking the system to make it better or more fair?
There's been a lot of...
more effective?
Yeah, sure. No, there's been a lot of talk every year at the meetings. There's always talks about how to try to reallocate organs, and they've talked about bringing other lab values into the system, also to try to expand sort of the regions that organs are shared in. There's been a lot of talk, but nothing has really been shown to really have changed basically how people do on the list.
And what about other health issues or challenges that a patient might have? For example, if a patient has serious heart disease as well and is on this list, is long-term survivability factored in any way?
I guess it's sort of up to the discretion of the people that are listing. Those sort of comorbidities aren't taken into consideration when calculating a MELD score. In certain circumstances, we're able to apply or appeal to the board that sort of approves everybody to try to get additional points. So if somebody we feel is unfairly, whether their disease severity is unfairly reflected by MELD, we can try to appeal to get them extra points. But it's very difficult to do, and a lot of times those people aren't approved, and we tend to really try to stick to that system. But other comorbidities aren't really taken into account. It's sort of up to the discretion of the transplant team to say, you know, is this patient going to survive, number one, on our list, and number two, are they going to survive long-term after?
But there is a team, and there is a human component. At some point, there is a human component. Absolutely. I think that's important to point out.
Yeah. If I can interject, I think it is fair to say that the system can be tweaked, and that what that does is achieve a reallocation of the same organs to a different group of patients. But the bottom line is that we do not have enough organs to allocate to all our needy potential recipients.
Okay. Dr. Reichman, why do we need to have living donor transplantation in Louisiana, and why is it important that we have that now?
So we over the years, and across the United States, not just Louisiana, more people are being listed for liver transplant every year, and the amount of available organs every year continues to sort of remain the same amount. So we're listing more people, and we have less organs really to allocate to them. So living donation offers a lot of benefits to people. Number one, it's one way to deal with the organ shortage. It's another option for people for liver transplant. And it really gives them the benefit of getting transplanted when they have a low MELD score, when they're physically well. They don't have to get sicker and acquire a higher MELD score to get transplanted. And really the goal is to try to prevent some of those waitlist deaths that we see every year.
Okay. Why does living donor liver transplantation work?
So we learned from doing liver resections that we're able, and you mentioned it before, that we're able to take a portion of the liver from a person, and over time, over about 6 to 8 weeks, that the remaining segment of liver that's left behind in the donor or in the person that's had the liver resection will grow back to basically whatever the volume or mass of liver that patient needs. So because of that knowledge, we know that we're able to resect a portion of liver from a donor, and that it's going to grow back over time, not only in the donor, but the segment that's transplanted and the recipient's also going to grow. We know from long-term studies that donors do well long-term, that there doesn't appear to be any major health risk to donors long-term. Obviously, there is some risk associated around the surgery operation, of course, but long-term there's no risk. And we know that transplanting a partial segment into a recipient is, in many cases, as good as a full graft, and that recipient survival is almost as expected if they had gotten a full graft.
Perhaps partly an ethical question, but I know it's one that's out there. Are patients compensated for these donations, or at the very least, all expenses covered?
Well, they're covered. Their expenses are covered under the recipient. So all of the donor medical expenses, for the most part, are covered under the recipient's insurance or however it's being paid for. Obviously, they're not compensated for loss of time at work and those kind of things, but at least the medical expenses are covered. There is obviously there's no monetary component, or that's actually one of the criteria for actually being able to successfully donate, is we don't want there to be, and there can't be any sort of monetary sort of exchange or any sort of coercion that's involved in trying to get people to donate. It has to be a decision made by the donor, and something that they want to do for a loved one.
And not necessarily in this country, but is there still a black market for kidney and liver donations
absolutely.
Overseas?
Sure.
There is. Mm-hmm. Okay. How common is live donor liver transplant in the United States? Obviously not common enough for the both of you.
Yeah, no, living donation started back in 1989, was first done at the University of Chicago, and in this country was first done at the University of Chicago successfully, in a pediatric, or an adult to a pediatric recipient. Since then, it's been slowly increasing. It accounts for about 5% of all transplants done in the United States currently. But there's only really a handful of centers that are really currently actively doing it, and doing it at a reasonable amount of volume. Last year, in 2011, there was about 250 transplants total, living donor transplants total.
And we want to point out, and the reason you're here, it is being done here at Oxnard, New Orleans.
Yes, we're starting.
Okay. Let's talk about kidneys for a moment. Mm-hmm. If it's 5% liver, that means a whole lot of the other ones are kidney donations. Why do you think kidney donations are so largely and widely accepted?
Mm-hmm. Well, kidney, it's been around for much longer. I think that the center's experience with it is a lot more. There's probably less morbidity associated with the donor operations, and the donors do really well. We've modified some of the techniques at Oxford to incorporate the robot into doing these surgeries, and because of that, donors often are only in the hospital for about 24 hours and able to go home really the next day after they donate. And recovery time is pretty minimal, and obviously the recipients do really well from getting a living donor kidney transplant. So the donors do really well, and the recipients do really well, and again, it results in a timely transplant for somebody who's really in need.
Do you think it has anything to do that we have two kidneys? we only have one liver, and yes, you're telling me, and the facts are the liver does regenerate, but I know I have another kidney. If it's a liver donation, although you're only taking a portion of the liver, I mean, I learned from doing this program that the liver regenerates, so it's not something that's probably widely accepted. Do you think just the number, we have 2 kidneys and only 1 liver, has something to do with those numbers?
Sure, probably to some extent. Although you're only lacking that part of the liver for about 8 weeks, which is potentially one of the advantages to living liver donation is that is going to come back. And
so a big part of your job's education.
Absolutely,
that's right.
Yeah. Okay, and we're helping with that tonight. We certainly hope. Now we want to listen to someone who has donated. This is a kidney transplant patient, so take a look at this.
Have you ever considered being an organ donor, but your concerns or questions prevented you from making a decision? Let me introduce you to 2 women who used to be co-workers here at Nicholls State University in Thibodaux. Their story will convince you that organ donation is the right choice. Mary DeLon and Gail Richard both started working in the same department of Nicholls State University in June of 1990 and quickly became the best of friends. That friendship became even closer when Gail started having kidney problems.
I first started having problems in the early 80s, and I was more or less on a special diet and medication. And then through the years, the kidney failed, and I had my first transplant in May of 1995. And that kidney lasted about 12 and a half years, which is a good record. And at that point, I needed another transplant. I was down to 13.5% function.
Gail received her first kidney donation from her first cousin. Her second kidney was donated by Mary.
Gail came to the office one day to meet me for lunch, and she said, I just want you to know that I'm going to need another kidney transplant. And I said, well, what do you have to do for that? She says blood work. I said, okay, let's give it a shot.
They were a perfect match, and plans for Mary to donate a kidney to Gail got underway. Mary admits at first she was scared and that many of her family members weren't originally supporting her decision.
I was a little scared. I wasn't quite sure. I really kind of expected it, but I didn't. What I did when we went to blood work, I said, God, this is yours. I'm putting it in your hands. If you want me to donate this kidney, then you're going to have to make it happen. And when I got the call, I knew that God had made it happen. Once I got over the nervousness, I said, God, I made you that promise. So the nervousness was gone. I never was nervous again throughout the whole procedure, even the day I was being rolled in. And that really helped my family because, you know, with your family, you don't want to see any of your family members go through anything. And when they saw the faith that I had and knew that, hey, I was okay with it, then they were very satisfied.
Gail's second transplant took place in October of 2007. Both Gail and Mary say they've had smooth recoveries.
I was actually out 6 weeks. They say usually a normal recovery is 4 to 6 weeks, depending. I felt wonderful. I could have gone back to work the next day. It was really, really an easy recovery.
I'm feeling a lot better. I have more energy, and just it's a better quality of life. I can do more things that I wasn't able to do before. I don't get as tired and just run down. Before maybe I would say go shop, and well, the next day I had to do what I call payback. I had to rest. But now I can do more things and not be as tired, and I feel a lot better. For me, it happened twice in my lifetime, and it's something that you can't hardly explain, the feeling that somebody would be willing to give you the gift of life. You're sick and you don't feel well, you don't have energy, and I guess the alternative would be like dialysis, and that ties you down where you really don't have a life. So to me, every Mother's Day, I feel like I have 3 mothers now because 3 people gave me life.
For more information on organ donation, call 1-888-521-GIVE or go online to lopa.org.
And we thank Stephanie and the patient and the donor for the donor and the recipient for sharing their story. Well, Dr. Therapondos, how does a person become a donor? What's the easiest way?
Well, there is a defined process behind working up somebody for a living donation. First of all, the request has to come from the donor themselves. They have to contact our program to say that they're willing to donate part of their liver to a friend or relative. Then they would receive a questionnaire from us that they will fill in, send to us without being seen by us. And if the questionnaire is satisfactory and if we pre-screen them and they don't have any prohibitive medical conditions, we would proceed with a physical workup, a consultation with ourselves, a physician and a surgeon to assess their suitability for this. And beyond that, we will proceed with a number of detailed medical investigations that include blood work, x-rays, scans, and finally they will be seen by a patient advocate to make sure, to determine that they're not doing this under any sort of coercion, and also to determine that they're not being coerced by ourselves, which is potentially one of the accusations that we can come under. Mm-hmm. And once this process is completed, there will be a determination of the exact operating time, an agreement amongst the team as to when to proceed with the actual donation.
You said a family or a friend. Do you have cases where people say, you have 3,000 people 2,500 people who died on the list. I'd like to help somebody, even though I don't know who they are.
Well, in our previous institution in Toronto, the University of Toronto, we had quite a few cases of what we called anonymous living donation, where just members of the public called us and offered to donate part of their liver to anybody that we would choose who had been waiting on the list for a long time. Usually the process of working these people up is much more involved because we have to make sure that they're doing this for genuine reasons. But we actually did a number of these successful procedures, and things worked out very well.
What are the surgical considerations involved in liver donation?
Okay, so as part of everybody's workup, they need to get, as George mentioned, a series of abdominal imaging that gets done. Everybody gets a CT scan and usually an MRCP, which is used to determine the anatomy of the bile ducts. And basically there's several criteria that need to be met. Number one, the blood flow into the liver, the hepatic artery, and the portal vein have to be suitable to be split so that obviously the segment of liver that's left behind is going to be able to survive on that blood type, and also the recipient, the half that they're getting also is going to be suitable for transplantation. The veins or the outflow of the liver, the hepatic veins, also need to be suitable. And then we do an MRCP to also look at the bile ducts and make sure that those, also similar to the arteries and veins, can be split into two different, one half for the donor, one half for the recipient. And then also the volumes need to be calculated so that we're leaving enough liver behind in the donor, and also giving enough volume to the recipient so that they're going to be able to survive and give the liver some time to regenerate, to completely restore function for them.
Is blood type part of the equation?
So it is. Basically, you have to have compatible blood types.
So not necessarily the same.
Doesn't have to be the same. So an O can donate basically to anybody, similar to blood transfusions.
Okay. Yeah. Very good. What are the outcomes of live donor liver transplants in children?
So for children, they're excellent. Like I mentioned earlier, the first successful one was done in 1989, and that really, for some time, was really the majority of living donor transplants that were done, at least in the United States, were adult to pediatrics because the results were so good. And really, the results are excellent in both the donor and the recipient. The donor, because the volume of liver needed for the kid is much smaller. The resection is much smaller for the donor, so the chances of complications are really minimized in the donor. So the donors actually do really well. As far as the recipient's survival is equivalent in most cases to if they've gotten a full graft, and in some cases, depending on the age of the child, it's actually even better. And again, the success also depends on organ availability within the region that you are. Obviously, where there's longer wait times, the difference between living donation versus deceased donor donation is going to be even better because of the timeliness of the transplant.
And you talked earlier about the importance of when someone receives the transplant, that better, or at least I got from your answer, that it would be better when someone's healthy rather than when they are sick. Does that have anything to do with the long-term outcome?
It doesn't. We don't think it has too much to do with the long-term outcome, but it definitely has something to do with the short-term outcome. So again, because of MELD, people tend to be a lot sicker and have a lot of are really debilitated from liver disease, whereas and those patients a lot of times are already in the hospital for several weeks or have been in and out of the hospital for several weeks, so they're really deconditioned when it comes time to transplant. So their recovery time long term and the chances that they're going to have complications after surgery tends to be higher because their overall condition is a lot worse. With the living donation, obviously everything is optimized, it's done electively, and those complications can really be minimized.
Dr. Therapondos, what about outcomes in adult? That was in children. What about outcomes in adult recipients?
Well, outcomes in adult recipients are equally good. The controversy in adults and living donor liver transplantation are not to do with the outcomes in recipients, but the controversy is to do with the perception, perhaps, that there is a risky procedure for the donor. In terms of the recipients, they do extremely well. As Trevor already mentioned, recipients receive about 60% of the liver volume from the donor, and the outcomes are equivalent to deceased donor or cadaveric donation.
And what about percentages? Because in neither case did you mention percentage of outcome. So what percentage of patients is a liver transplant a long-term fix?
Well, I think it's the same for children and adults. I think, as you mentioned earlier, the outcomes in children, in adults often depend actually on other comorbidities. So it is not unusual for the liver to continue working into old age, and for the recipient perhaps to have other complications such as cardiac disease or other problems. In terms of how well the liver does, we know that our one-year outcomes are particularly high, above 90%, one-year survival. 5-year outcomes are approximately 80%. And, the same is true for living donor and deceased grafts.
Okay, very good. Our guests are Doctors Trevor Reichman and George Therapondos, and tonight we're talking about live donor transplantation, particularly in the area of liver and kidneys. The time to ask your questions is right now. You can call us at 504-866-3200. That's 866-3200. And again, you can call with your questions as we speak. Our email address is hhquestions@wlae.com if you'd like to ask your question that way. Dr. Therapondos, what are the benefits of LDLT?
The major benefit, as Trevor again alluded to, is the fact that you don't have to wait on the list until you become extremely sick to be able to be allocated a liver. So again, optimization of the patient before they become sick at the time that's suitable to the recipient and the donor leads to better early outcomes, but also it prevents essentially death on the waiting list. As you can see from the graph that we're showing you on the right-hand side, the slightly darker line indicates the outcomes from living donor recipients. The gray line shows the outcomes of people who waited on the cadaveric waiting list, and some of them died waiting. So you can see that the outcomes overall from the time of listing, from the time of being placed on the waiting list, were superior for those patients that had a living donor.
And looking at the outcome for donors, is the outcomes there?
I mean, I think this is very important to consider. We all know that, again, as we discussed earlier, there are complications from the procedure in the first week or the first 30 days. That's when we do see outcomes. There has been concern in the past about the lack of information about what happens to donors in the long run because of lack of follow-up and because the procedure was relatively new in the past. But we now have information partly from Asia and partly from our own university before, the University of Toronto, that we know that donors do extremely well and do not seem to suffer any long-term problems. We have long-term follow-up up to 10 years or more.
And finally, Dr. Reichman, what have we learned from LDLT that can benefit non-transplant patients?
So obviously from our work that we did with resections initially for cancer, we were able to determine that we were able to actually do living donation, that we could take a partial segment, and also some of the information we learned from split liver transplantation. But what we've learned from living donation, from doing the operations, is really a better understanding, I think, of the anatomy and how to preserve a lot of those structures in the liver that allows us to do even larger resections, because we're able to preserve certain anatomy within the liver. So people that in the past were thought to have unresectable cancers, because of a lot of the techniques we've learned from living donation, we've been able to translate those back into doing cancer resections and resect people that were previously thought to have a terminal disease or unresectable cancers. And in some cases, we've even been able to almost do a living donor operation, essentially resecting, removing the liver, resecting off the benign or the section of liver that was not affected by the disease, preserve that segment, and actually reimplant that into the same recipient.
Very exciting.
Yeah.
Well, if you have questions about anything we've discussed tonight on the recipient side or the donor side, you can call us right now, 504-866-3200, or email your questions to hhquestions@wlae.com. This is Hello Health on LAE, and we're back with your questions in just a moment.
I'm Meryl Streep. Can television make a difference in our lives? It does make a difference. Television changes you, so it's important what you watch, when you watch. That's why I support public television, and I hope you will too.
Welcome back to Hello Health on LAE, more than television. Tonight we're talking about live organ transplantation with two doctors, Trevor Reichman and George Therapondos. George Therapondos is to my left, and to his left is Dr. Reichman. Let's start with line 3, where Jill is calling us from Bay St. Louis, Mississippi. You know, I'm from the Mississippi Gulf Coast, so that's why we put Jill first. Jill, welcome to Hello Health. Good evening.
Hello.
Good evening, Jill. Go right ahead with your question for our doctors.
Hi, my husband is a 46-year-old male, and he has 4-stage cirrhosis of the liver, and they're getting ready to do they're taking a piece of his liver from his daughter. What is the survival rate, and they're giving it to him for a recipient to a donor?
Who would like to take that?
What's his background cirrhosis caused by?
Jill, go right ahead. What is it that caused the cirrhosis?
Alcohol.
And he's getting ready to receive a piece of liver for a transplant?
From his daughter.
From his daughter?
What?
Yes.
Yeah, I think the success...
it was alcohol that caused the cirrhosis.
Okay. Thanks for your question. Well, the outcome, the chances of success are very high. I would say that the chances that things will go well and he'll have a very successful outcome in the first year at least are over 90%. And as I said before, his chances of success in the long run over 5 to 10 years are probably in the region of 80 or 75 to 80%. It's difficult to say to talk about individual cases without knowing all the details, but this is the kind of ballpark figure we'll be talking about.
Very good. Thank you so much, Jill, for the call. Line 4 is next. Gina calling us from New Orleans. Gina, welcome to Hello Health.
Hi, how are you?
Fine.
I am calling to find out if there's any age limitation for a donor.
Good question.
So I guess we've said in the past, no one over the age of 60, so 59 and younger, has typically been our cutoff. But again, as George was saying earlier, it sort of depends on also on comorbidities that are present. But as a general rule, 59 or younger is our cutoff.
The first caller was mentioning that the father was getting it from the daughter. What about on the that's on the older side? What about on the younger side? At what point, at what age could someone donate?
So we usually say they have to be of consentable age. So in the past, it's usually been 18 has been sort of the lower limit that we've accepted. In Toronto, we actually, and special circumstances, would accept younger donors, but for now, it's 18.
Okay. Let's go to line 5, where Emma is on the phone with us from Metairie. Emma, you're on with Dr. Therapondos and Dr. Reichman.
Thank you. My question is, do recipients of living donors require less anti-rejection medications?
That is a very good question, actually, and unfortunately they do not. They require the same amount of anti-rejection medications, and there is an argument that in the early stages they may actually require a little bit more. But that is debatable. In general, I would say that the amount of anti-rejection medications in the long run will be about the same.
What are the challenges with anti-rejection medication?
Well, there are lots of challenges. The anti-rejection medications cause a lot of side effects potentially, but we're getting very good at managing those side effects. They can cause some kidney dysfunction, then they can cause some hypertension, they can cause high cholesterol and lipids. But these days, we after the initial first 3 months, we managed to reduce the anti-rejection medication significantly. So patients, these days use a lot lower doses of anti-rejection medications than in the past.
Okay. Let's go to Phyllis, who is on the line with us on line 1 from Kenner. Phyllis, good evening. Welcome to Hello Health.
Hello, how you doing?
Fine.
This question, pardon?
Go right ahead, Phyllis.
Okay, this goes out to either doctor. I'm a heart patient, and I was just wondering if either doctor is familiar with milk thistle as a cleansing agent for the liver, because I take heart medicine amongst other types of medication.
Okay.
Yes, I'll take that question. The milk thistle is a herbal medication that is thought by various practitioners of alternative medicine as being useful in the field of liver medicine. It hasn't really been demonstrated in any scientific studies that it has any significantly beneficial effect in liver disease. One thing I would say is that it probably does not have any harmful effect. We certainly don't recommend it to our patients because we don't have the evidence that it does any good, but it probably doesn't do any harm.
Is there anything else that you would recommend that has proven to be helpful, either with liver disease or keeping the liver healthy?
Well, I mean, there are a lot of so-called liver tonics on the market, and generally those liver tonics that are sold in various health food shops are not proven to be of any benefit. there is a big industry out there trying to promote these alternative medicines, and most of them do not have any beneficial effect. There isn't one drug that will be beneficial in all types of liver disease. It really depends on what type of liver disease specifically you have. In general, I would say that once you have cirrhosis, there is nothing to reverse that. Once you have cirrhosis, we can treat the complications of cirrhosis, and we can treat the symptoms, but we cannot reverse the background disease.
Okay. I take fish oil to prevent heart disease, and I take a baby aspirin. I'll ask you this question. Is there anything you take to prevent liver disease? Or you can jump in there too, doctor.
No, I think it's just, like you say, common sense. I mean, just avoiding sort of the things that, obviously, alcohol excess,
fatty foods, watching your diet, all those things, are going to prevent potentially developing liver disease. It is, as George mentioned earlier, a little bit unpredictable about who actually is going to progress to cirrhosis, or, how many drinks is too much. But I think just, using common sense and sort of everything in moderation is probably the best advice. And certainly both of those things are proven, and you can control those.
That's right.
Absolutely.
Yes. Well, let's go to Carol next on line 6, calling us from New Orleans. Carol, good evening. You're on Hello Health. Sounds like we may have lost Carol. Carol, we'll invite you to call back. 866-3200, 866-3200 is our number. Susan is next on line 2. Susan, go right ahead with your question.
Yes, this is for either doctor. I would like to know, with my family history, I've already lost one brother to alcoholic cirrhosis. My older sister, who's 59, was diagnosed over 10 years ago with hepatitis C. Now, she did a therapy, antiviral therapy, I think it is, and she got better, and she's doing okay now. So this is my question. If her hep C returns, would she be eligible for liver transplantation if I was willing to be worked up as a donor?
Thank you, Susan.
I mean, it's difficult to know, Susan, without knowing the details, but I can't see any reason why not. I think if her hep C deteriorates or returns and she has liver failure or has liver cancer, then I think she would be a good candidate for transplantation.
Dr.
Pretty much anybody who is eligible for deceased donation is eligible for living donation, with a couple of small, sort of more technical things that have to do with the surgery itself. But pretty much our guidelines are, if you're suitable to be listed for a deceased donor transplant, you're suitable for a living donor transplant. So most people are eligible.
Thank you so much, Susan. Let's go to Nancy, who's calling us from across the lake in Lacombe tonight. Nancy, welcome to Hello Health.
Yes.
Go right ahead with your question.
Can you hear me?
We can hear you just fine, Nancy. Go right ahead.
Okay. I'm 71 years old, and back in '94, a doctor overdosed me on anti-inflammatories, which damaged my kidneys. And then I had a useless angiogram done 2-3 years ago, which infected my blood, which worsened my kidney problem. Now, my kidneys are functioning, but I've got a port in me, and I'm doing dialysis. I have a donor who's probably 100% match. At my age, do you think it will succeed?
Sure. No, it's we really don't have an age limitation as far as it sort of depends on your overall condition. And again, without seeing sort of the specifics of your case, it's hard to say whether it would be suitable to do. But in being 71 is not necessarily a limitation. It sort of depends on kind of your overall health and whether, number one, whether your body's healthy enough to survive and make it through the surgery, but that also that long-term that you're going to do well with a kidney. So, but age per se is not we don't exclude people per se just based on age.
Okay. Thank you, Nancy. Bill is next, calling us from New Orleans. Bill's on line 4. Bill, you're on Hello Health.
Hello.
Hi there.
Good evening.
Good evening.
I had to cut the television set off so I could hear you. You still with me?
We're still with you. Go right ahead, Bill.
Okay. Just a couple of questions. I'm really enjoying your program. I'm 85, and I have a number of problems, high blood pressure, cholesterol, and that sort of thing, which I'm taking medicine for. Recent tests have shown that I'm using only 40% of my kidneys, 45% anyhow. And I was just wondering, I'm not taking any medication for it. You still with me?
We're still with you, Bill.
And I'd like to get an opinion of your doctors as to just on what my situation is. I know they're not examining me, but let's say I'm 85. I have other problems. My kidneys, I'm only using 40% of them. And so it's sort of a wait and see when it gets worse, I guess. I don't know. But could you give me any idea of...
So, Bill, your question is, would you be a candidate for kidney transplantation?
Well, I imagine I would be. But that wasn't my question. I just want to know just how bad the situation is with only using 40% of my kidneys.
Sure, no, but it's hard to predict, without knowing the rate of the decline of your kidney function. It's really hard to predict. A lot of people can go on with 40% of their kidney function for I mean, we do essentially with living donor kidney transplantation, you're only transplanting 50% of 50% of whatever a normal function is. Yeah, so a lot of people can do quite well with just 40%, and it sort of depends on just the rate of decline of those kidneys. So it's really hard to say.
So if he wanted a better answer, more specific answer, he might go see his primary, start with his primary care physician and move from there.
Yeah.
Okay. Thank you, Bill. Let's go to David, who's calling us from Slidell this evening. David, you're on Hello Health.
Hello.
Go right ahead.
Okay. In 1996, my wife donated a kidney to my daughter, and my question is, what happens to her now, 10, 15 years later, and what is her survival rate, and what happens if she loses a kidney?
So survival very similar to living donor liver transplantation, and actually we have more data dealing with kidney donation. As far as we can tell, long-term survival for people that have donated kidney is no different than the general population. So it's not going to shorten your life. And as far as we can tell, there is really no long-term, at least no major long-term consequences to. And more importantly, there doesn't appear to be any increased risk of her needing a kidney transplant or needing dialysis long-term in life because she's donated.
So if she was going to get kidney disease, she would have gotten it with two, just as likely to have gotten it with two kidneys than she would have
absolutely.
With one.
As long as, yeah, absolutely.
Okay. Let's go to Frank, who is on line 2. This may be our last caller of the night as we're running a little short on time. Frank, calling us from Uptown. Welcome to Hello Health. You're our last caller of the night.
Good evening, gentlemen. I had a quick question in inquiring whether or not Ochsner plans on starting the live liver donor program, and if so, when?
Thank you very much, Frank. Great question to end on.
So I think that is the reason we're here, to promote the start of our living donor program. So we've been preparing for this for the last 6 to 9 months, and we're now ready to start this program.
So hopefully in the next month or two. We've had some donor recipient pairs that have started to go through the workup and or are in workup right now. So hopefully in the next couple months we're looking to do our first one.
I would imagine it's a very exciting time for both of you.
Yeah.
And we're certainly prepared to start looking at potential donors right now.
Okay, so don't wait till you open the doors.
No. Well, the doors are open right now. Yeah.
Very good. Well, we thank you both very much for being with us. Dr. Therapondos, Dr. Reichman, thank you both for the education and information you provided tonight and for your work at Ochsner and for being here in our city. Thank you. All right. Well, let's take a look now at what's coming up on Hello Health, our calendar of events. On Monday, April 30th, Dr. Jody Morris will join us to talk about the new age of gynecological surgery. That's on our next live program. Dr. Jody Morris, Monday, April 30th, right here on Hello Health. To make an appointment with any Ochsner physician, you can call a special number or to register for any of Ochsner's Hello Health seminars. They take place almost every week across the city. You can call Ochsner at 504-842-5669. That's 504-842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at ochsner.org. Just type Hello Health in the search areas. Our thanks again to tonight's guests, Dr. Reichman and Therapondos. Thanks to Humana and Ochsner for always making this program possible. And our final thanks, as always, is to you for your support of this program, Hello Health, and our station, LAE, more than television.
Health on LAE has been presented by the Ochsner Health System. 600 physicians in 80 medical specialties working with a team of more than 10,000 employees to provide nationally recognized health care across Southeast Louisiana. Ochsner, health care with peace of mind.
I call it my one less thing to worry about plan. With a Humana Medicare Advantage health plan, I get more clear information about my options with 24-hour access to my Humana, my secure website, and I can get help every step of the way from a Humana Market Point representative.
More of what you want because you deserve more.